Okay, welcome to the 39th meeting of NHS Richmond Clinical Commissioning Group Governing Body meeting. My name is Graham Lewis. I'm a local GP and chair of the, I will attempt to chair this meeting. That means keeping us to time. For those of you who haven't discovered them, toilets are out those doors and to the left, both men and women. There are no fire alarms expected, so if the fire alarm does go off, try and keep up with me as I go through the doors behind you, marked with a green fire exit symbol, and we will all collect ourselves on the car park far away from the building. I am aware that some colleagues may be on call, but if they're not, could they turn their mobile phones to silent and all their other various bits of technology that are liable to go off at all the wrong times? This governing body meeting is in public. That doesn't mean it's a public meeting. In relation to questions from members of the public, the CCG is committed to openness and transparency and therefore wishes to conduct as much of its business as possible in a session that the public can attend and observe. Although the meeting is held in public, it's not a public meeting. This means there is no opportunity for the public to ask questions apart from that offered at the chair's discretion. There is a specific slot at the end of the agenda, and we've always taken questions from the floor at the end of our meetings. Governing body meeting is also being video recorded, as part of the commitment to make information as accessible as possible, and there is a camera behind the public area. This video will be put onto the website within a few days of the meeting. CCG does not allow any other recording of the governing body unless agreed by the chair prior to the meeting, and I don't think anybody's asked to do that. CCG has a protocol setting out how it will conduct its meetings, and this is available on our CCG website. I think that's all the formal things. I would remind members, unlike some of the other places we met at, you do not need to touch this. I've discovered that by painful experience, so the gentleman to my left will adjust everything so that we are broadcast. Do we have any apologies, Chair?
Sarah Blow, Anne Dornhorst, Catherine Yates, Sylvia Ferguson and Liz Bruce.
Okay. Any new declarations of interest since people last put them on the website or since our last meeting? Marvellous. Can we take the minutes of the last meeting, as long as my technology works? So, page 1 of 12, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, or 12? No. Thank you, Joe, for your good minute keeping as always. The action log. So I've got GB 101, which I understand is completed. GB 102, which is completed, and GB 103, which are completed. So they will be removed from the log for next time. And I understand Liz Bruce, unfortunately, is not here. I think she took that away from the last meeting. I don't know that there's a further action on that. And the emergency preparedness, resilience and response assurance outcome. Fergus, do you have any feedback on that?
So just to say that I need to have a further discussion with Tonya, so I'll report back at the next meeting, sir.
Okay, so that's on track as well. Excellent.
Chair, can I just ask on GB 103, the end of life care, the communications part which is completed, it would be good to see a copy of that.
Yes, I'll make that available.
Can we?
Sorry. Yeah.
Thank you. Thank you.
Okay.
Thank you.
Okay. Any other comments on the action log? Okay, I'm going to There's items taken in private last time are listed here. It says for approval, but I'm assuming that everybody who was there last time remembers and approves those. CCG Chair Report, we've got 2 thorough reports coming up from, well, I've got our Managing Director report. I'm not really sure that I have much to add other than to remind people who haven't done so. There was the new GP contract that came out on the 31st of January, which is exercising a lot of my colleagues. And if people haven't read that, I would encourage them so to do. I'm going to hand over to Tonya for the Managing Director's report.
Thank you, Chair. And as you say, it's quite an extensive report this month, so I won't go through it line by line. And it's an exciting time in the NHS at the moment. We've had the long-term plan, which I'm going to have a bit of a chat through later on in the agenda, and lots of new ways of working emerging. And one of those things is around how the CCGs start to work together in a different way. And it's time for us in South West London to review the way we work. So we've been working together as 6 CCGs for over a year, and we think we can do things better together for the benefit of our patients. The National NHS Long-Term Plan and its emphasis on the new primary care network and the indication that NHS England expects the CCGs coming together in STP areas. And for South West London, this means that we're exploring what functions we could hold across South West London as a single CCG, and the strengthening of local health and care partnerships and the development of the 6 local health and care plans. So we've just had a long discussion in our part 2, and in that we've agreed to begin the conversation with each GP membership with an initial case for change, that the GP membership and the CCG staff will be involved in designing the way we work going forward, that we will create a governance oversight committee which will include lay members, and a leadership forum which would be created for senior CCG staff. There will be lots of opportunity over the coming months to have more discussion, debate around what this looks like, and I expect this to become quite a regular item on our governing body meetings. So the start of a process today. Moving on, Time to Change pledge. Sarah Blow, Accountable Officer, signed a Time to Change pledge on behalf of Kingston and Richmond CCGs on the end of last month at Thames House. Time to Change is a campaign run by Mind and Rethink Mental Illness, and by signing up, we are demonstrating our commitment to change how we think and act about mental health and ensure that colleagues who are facing these problems feel supported in our workplace. We've got 13 staff volunteers who have agreed to be mental health champions and who will receive training over the next few months. So that's a really good, positive pledge made by both CCGs. We have had our staff survey results. We've had a really good response rate, so 96.2% of the CCG staff filled in this year's survey. I had asked them 80%, so we've exceeded my ask. We're currently reviewing the results through our Ways of Working group, and we will be drafting an action plan which will come back to governing bodies in due course. And then moving on to our latest rating on the Improvement Assessment Framework. The CCG Improvement Assessment Framework aligns key objectives and priorities for NHS organisations in delivering the 5-year forward view. And as part of the CCG IAF, quality of leadership ratings are reviewed on a quarterly basis. Following the latest review, the leadership rating for Richmond CCG has moved from green to amber, and the change in rating is due to concerns that NHS England London has around the need for significant improvements in the governing body's leadership to drive the necessary transformation across primary care and community services, and also the CCG has a challenged financial position. I'm really pleased to say that it takes quite a long time for these ratings to be made and published, and actually we have seen significant progress in both our relationships and the work that we're doing to transform care. So I'm confident that in a not too distant future we'll be able to regain our green status on leadership. But we have, in light of our financial position, we have focused over the last few months on developing our transformation programme in Richmond, and we're working in partnership with health and care partners in the borough to develop the shared priorities. So I think we've got a really positive piece of work going forward. So though it's a disappointment to the governing body to have received a change in rating, I think we can demonstrate fairly quickly that we will be able to regain our green status. We've also received ratings for service areas, specified service areas, mental health, dementia, learning disability and diabetes. I'm pleased to say that overall Richmond received either outstanding and good for cancer, maternity, mental health, dementia and diabetes. The one area where we have received requires improvement is learning disabilities, and this is a common rating for CCGs. The learning disabilities rating looks at reliance on specialist inpatient care for people with a learning disability and autism, and the proportion of people with a learning disability on the GP register receiving an annual health check, and the proportion of the population on a GP learning disability register. We know we need to do better in this area, and in that respect, we are appointing, if we haven't appointed already, a GP clinical lead who will develop and support delivery of programme work to drive improvement in this area. We've also, our local providers have also received their annual assessment on cancer outcomes, and I'm pleased to say that for 18-19, our main provider of cancer services, which are Kingston Hospital, Royal Marsden and St George's Healthcare, have been judged to be compliant, and they for all their areas of measurement, and that means that they will be on a routine surveillance, which means that there are no concerns about the cancer delivery at those three trusts. And another development for cancer, we now have appointed a Macmillan GP for Kingston Richmond. That's Dr. Sinead Moran, who is a partner at Shane Lane Medical Health Centre. And her role is to ensure that we promote the priorities of our cancer strategy, and that to particularly focus on early detection of cancer, and that we have the right support available for people living with and beyond cancer. Our public sector equality and duties annual report is available for review on our website, and we approved that at our executive management team in January, so I won't go through that. You can read the report, the links provided. We talked just now, Susan raised end-of-life care. I'm pleased to say that GP practices in the borough will now be able to display a daffodil mark as a sign of commitment to improving end-of-life care, which is a really positive move as well. And then also, I'm going rapidly through this, guys. I didn't realise it was quite so long as this. Connecting Your Care is about how we share records. So for people registered with a GP in Richmond, Connecting Your Care will be joining up GP and hospital records for South West London hospitals. So GPs, along with doctors and nurses, will be able to immediately see important information about their patients through a secure system to help them make more informed decisions about their care. And then finally, you'll be pleased to know I'd like to thank the CCG staff who have volunteered as winter champions this year. That's been really positive. We've seen a real positive impact, and it's been great to go out and talk to communities about how they access care in times of clinical need. And we're encouraging people in their local communities and voluntary groups to share information to help members of the public stay well over the winter. I'm now finished, but I'm happy to take any questions.
Any questions from Tonya on her extensive report? Thank you very much. Next item is 1.7, Audit Committee Chair's report.
Just a few points, Chair. So, from the most recent meeting in January, we discussed the Business Assurance Framework report. Again, no major changes month on month there, but recognition now that we're not just looking at Richmond risks in their own right, but looking at the wider South West London system as well. So that was acknowledged and discussed. With the service auditor report, which is where we have the report based on our relationships and engagement with the third party, there were some minor issues around some controls, but again, nothing that was deemed to be a concern, so that was approved. I think the main discussions were around a number of internal audit reports we had. So first of all, on medicines management and governance, they were good reports, and we took reasonable assurance from those. I think the key one was obviously around the QIP situation and the finance management around that. And that only gave us a partial assurance. A couple of actions came out of that, which was about establishing the finance recovery group, which is now up and running, and also recruitment of a transformation director. So I think it's nothing new. It's something we've been aware of for a while, but there's recognition now that there are some obviously key actions that we need to take there. So I think those would be the key points, Chair.
Okay, thank you. Does anybody have any questions for Paul? No? Okay. I'm going to move on to item 2.1. As those who've read the Register of Interest will know, I have a clinical role with Your Healthcare, who are the provider of learning disability services for Richmond. So I'm going to hand the chair over to Bob for this item.
Sorry, and I need to declare that the team that deliver learning difficulties sublet part of my premises in Hampton Wick.
Fine, thank you for that. Right, Julia, you're going to lead on this, so I'll hand over to you.
Thank you, Chair. The Council for Health Law and People Learning Disabilities advise you that Your Healthcare, who is the residential service, had decided that they would no longer be looking to provide this care in this care setting. Just to remind everyone that it's an 8-bedded unit for people with severe learning disabilities and complex physical health needs. And it's actually situated in the borough of Elmbridge, and that goes back to the days when we had Kingston and District Community Health Trust many, many years ago. But currently the responsibility for delivery of that service sits with Your Healthcare, who were the community trust that emerged out of then the Kingston PCT. And Kingston CCG are the host commissioner. However, for us as Richmond CCG, we currently have 2 residents who have been placed in Wesley Lodge for a number of years, and therefore hence why we needed to make the board aware of this change. As a result of the change, we took advice through the Kingston Health and Overview Panel as because of Kingston CCG's responsibility for commissioning these services, just to clarify whether or not this was considered to be a significant change and whether we would need to go out to any form of consultation or engagement with regards to this closure. And that's why it hasn't been discussed in public until this time, because we had to go through that process. We also needed, having got information to that effect, also then needed to sit down with the individual residents and their carers and their advocates before we actually came out in public with regards to this matter. I'm pleased to say that the Health Overview Panel didn't feel that it was a significant change, and therefore we should go ahead with the process of working with the clients to find suitable alternative accommodation for them. And as part of the process of people being placed anywhere across, be it within receiving care at home or receiving or being placed, the CCG does have an annual review process that is undertaken to assess the suitability of that. So actually this was all part and parcel and included all of that was taken into account when we were notified of the closure. We also have a learning disabilities commissioner and case manager who's working with all of the residents for Richmond and also for Kingston, because of course we cross the 2 CCGs, with regards to finding suitable alternative placements for the 2 individuals that are Richmond residents. One of the compelling reasons for Your Healthcare deciding to withdraw and close the unit is, to a certain extent, the original intended purpose was for this to be a community-based accommodation with the opportunities for local people or the residents to integrate with local people and local services. In fact, where it is based, it is very isolated, and actually those aims have never really been fully met, and so actually it would become quite a challenge. Also, there were ongoing challenges with recruiting staff to actually work in the unit. And the type of accommodation no longer meets the needs for actually being able to deliver the personalised care that is needed. So it seemed appropriate this time to reconsider. And also it links into the conversation and the drive from NHS London with regards to transforming care for people with learning disabilities and then being placed in appropriate, suitable alternative accommodation. So really this report is coming to advise the governing body of this service change and to give assurance of process and progress in managing the transfer of the individuals. We're working with all the individuals and their families. We are thoroughly assessing them to ensure that we have a current understanding of their level of need, and we are working to find suitable alternative accommodation for them. And of course, as part of that process, they will be visiting that accommodation. To date, there's been no resistance from the family or the individuals who are affected by this. We have one individual who is subject to a court of protection, and we're working through that. But other than that, the expectation is that all of the residents will have moved to alternative accommodation by the end of this month. And say the placing authorities are all working together to that effect. The transfer of these patients will be in the existing financial envelope that we have in terms of funding for these individuals. Any slippage post-March will require discussion with Kingston CCG as the host commission with regards to them managing the void costs, which we've been notified of. So that's all I wanted to say. Happy to take any questions, concerns, issues.
Right, any questions for Julia? No? Thank you very much indeed for a comprehensive report. Yeah. Thank you. Right, I'll hand back to Graham for next item.
Thank you, Bob. So next item is about the provision of the ophthalmology service from Teddington Memorial Hospital. Sorry, Neil.
Correct. Can I just flag an interest? I'm a user of the Ashford St Peter's.
Okay, so I think you're on again, Julie.
Yes, another service change. So again in November, Moorfields Foundation Trust, who provide ophthalmology services, informed the CCG that they could it was no longer viable for them to continue to provide the two clinics that they run out of Teddington Memorial Hospital due to issues with staff to cover those clinics, and actually they'd seen a decrease in the demand for those services. The board will also recall that we have also been working with the local optometry committee with regards to looking at pathways for minor eye conditions as well, and part of that service was part of the service that also was being offered at Moorfields. As a result of the challenges with actually getting staff to work in the clinics, Moorfields came to us and advised us of their intent to transfer the service to other Moorfields sites. As the paper says, the Foundation Trust runs glaucoma and primary care eye services. For those coming into primary eye care services, it tends to be a see and treat or a see and refer into a secondary care hospital-based service. The other group of attendees were those with a glaucoma, and we have 338 glaucoma patients within the service who are considered to be stable and we're having 6 monthly review and follow-up. And those are the cohort for whom we needed to work with Moorfields and with the local individuals concerned to find alternative care settings for them so that we could transfer their care there safely and mitigate against any harm with regard to this change. So again, we went through health scrutiny panel. This time it was Richmond, and they again confirmed that they didn't feel this was a significant change and that we need to go out to wider consultation and engagement, and were assured that the work we were doing jointly with Moorfields in contacting the individuals and discussing with them the alternative offer to them, that was sufficient. So in transferring the care, we've written to all of the individual patients, and this was a joint letter from the medical director of Moorfields and Graham Lewis, our chair, asking people to identify their preferred location in terms of Moorfields clinics, and Moorfields are in many places in and around London, but specifically focused on Queen Mary's, St George's and the Nelson as being seen relatively local, but also they have clinics in Ealing which have also been seen as clinics people are interested in going to, but also offering them the opportunity to refer back into other providers of their choice if they so wished. if they really didn't feel that they could travel to these other places, because we do need to think about some of the Teddington is very accessible. Getting across to Queen Mary's is fine if the park's open, and St George's can be quite a challenging travel time and transport links. So we've written to all of the patients, and in the table within the report you'll see the responses so far from half those people who have come back and advised where they would like to go. A significant number are choosing and electing to remain with Moorfields. But we also have a number who have chosen to transfer their care to Kingston Hospital, and so we're working with them with regards to that safe and timely transfer, because the last thing we want to do is lose people to their regular screening and therefore that follow-up. We are continuing to contact patients, and there's a programme to follow up individuals to make sure that we know what their choice is, but equally as a fallback position, those from whom we have no response will be automatically booked into a Moorfields clinic, so again they do not get lost in the system. And to date we've received no real concerns or complaints with regards to this change. So this again is coming to the governing body to advise them of this service change, give assurance on the process and the progress that we're making in terms of effecting this transfer. And you're asked to note the contents of the report. And as I said, the big issue was about losing patients to follow up. And as I said, we are restratifying them so that we can ensure that patients get to the right clinics. So again, I think that was all I wanted to say, and take any questions, issues or concerns from the government.
Thank you very much, Julia. So this was for assurance of the process so far, and any questions or concerns from members of the governing body?
No, sounds robust.
Very good. Two questions then. Have the numbers progressed since the table that you've got here? Because we've got about a half, no, just under a half of respondents had replied. That was the first question. And the second question was, potentially up to 100 new patients could go to Kingston. Are we assured they have the capacity to manage that if the splits are similar to shown in your table?
I don't have any up-to-date figures from this. Apologies for that. We are discussing with Kingston how they are going to manage the safe transfer, and they have assured us that they can absorb the patients. It'll just be about booking them to the appropriate clinics. What we do also have in Kingston, in the Kingston area, which is for Kingston patients, is we do have a community glaucoma service that runs out of Hawkes Road by Kingston Hospital. So I would also look to that being offered as a site as well. And that's easy parking compared to the hospital.
Helpful. Branko?
Sorry, I just want to ask you about our community optometry service.
I was about to say that, Branko.
Yeah.
Basically, some of those numbers will reduce anyway, because a lot of these people who would have gone to Teddington Memorial Hospital would have just required monitoring and not treatment, and so they'll therefore be in the new pathway.
Okay.
With the optometrists, it's only the people that require actual treatment for their glaucoma will have to go on to secondary care, which was all part of the pathway anyway, so hopefully those numbers will reduce.
Transformation in action.
Absolutely. Question answered, Branko?
Okay. Any other questions for Julia or any other member of the governing body? No? Okay, thank you very much. I'm going to, thank you, Julia, move us forward to 2.2 in the report from the Integrated Quality Governance Committee. Fergus.
Thank you, Chair. And just to mention, as you recall, at the last governing body, we agreed the terms of reference for changing our Quality Safety Performance Committee to our Integrated Quality Governance Committee. And I'm pleased to say we've had two since then, and the feedback from those who've attended have suggested that that's working quite well and has improved the discussions that we've had around quality and performance. So I'm presenting this report today on behalf of Dr. Ferguson, and within the report I will go through our overall performance and some feedback from the CQRGs and other quality areas that we reviewed at the last meeting. The first thing to mention is the South West London Performance Report, which is attached as an appendix. It is quite out of date in terms of the month's report that we have, but I've included the most recent version, which was approved. So I think there is a discrepancy between some of the figures in that report and our more up-to-date position that we received at our most recent meeting. Overall, I'm pleased to say there's a largely achieving overview of our performance against constitution and local standards. There's very little change really since the last meeting that I presented this report. I'm pleased to say that we continue to achieve our diagnosis rate for people with dementia. And we have had significant discussions in previous meetings about our referral to treatment numbers, particularly the waiting list size at the beginning of the year compared to the end of the year. So I won't go back over that again. In terms of cancer standards, 8 of the 9 cancer standards are being achieved for the year to date. The one that is not green at this stage is the 62-day screening standard, but I'm pleased to say it's very, very small numbers of patients that have a disproportionate impact in terms of our performance. Mixed-sex accommodation breaches continue to be a challenge at Imperial Trust through the winter period, and we have discussed that at the committee in terms of the contractual issues that relate to the mixed-sex accommodation breaches. In terms of mental health, improving access to psychological therapies, one area where we're marginally below the performance standard is our care plan approach for patients who are recently discharged from the Mental Health Trust. And again, it's a small number of patients that were a challenge for us to connect with in terms of their care plan approach. Healthcare acquired infections, we've got an slightly improving position around our Clostridium difficile rates. Again, we received the report from the infection control team from the North East London Commissioning Support Unit. There's no specific actions for us to take to address that position. In terms of accident emergency waiting times, whilst we are not achieving the 95% target at Kingston Hospital, and we narrowly missed it on Chelsea and Westminster site, I'm pleased to say that our winter planning that we undertook in advance of this winter period that we shared back in November with the governing body has meant that actually we've performed relatively well in comparison to South West London and to the wider London area, and that has meant that we have sustained the minimal number of escalation beds during the winter period, and we've achieved excellent turnaround times for ambulance services. In terms of cancelled operations, again, a very positive position to report. And in terms of our delayed transfers of care, both of which are important elements around the A&E performance and the patient safety and experience at the hospitals have been good. But I wanted to congratulate Liz, although she's not here, and the work that the local authority has done supporting us around reducing the number of delayed transfers of care. And whilst our year-to-date position is just over the required level, actually for the winter periods, those levels have been the lowest that we've seen during the year, particularly for our social care delays. In terms of our operating plan supporting activity, I think it's largely the same as last time, in that there are a number of areas that we are marginally above what our operating plan trajectories were. We have talked in detail, as I've said already, about the referral to treatment volumes of patients, and we've had a deep dive here previously at the governing body in that regard. And again, we've talked about the numbers of new patients and referrals related to the increase in cancer activity. In terms of the improvement assessment framework, I won't go into that in much detail, as Tonya has covered a lot of that already within her Managing Director's report. And the quality premium dashboard, again, it's a mixed picture, but there are a number of areas that we're very pleased in terms of our performance. So particularly I'd call out the continuing care performance. We've done a lot of work around managing the financial impact of continuing healthcare, but I'm pleased also to say that some of the quality measures around that, particularly the timeliness of assessment and the location of the assessment, we're doing very well as a CCG in that regard. Moving on just to talk about more of the qualitative aspects of the meetings that we've held. We had reports from Kingston Hospital Foundation Trust and South West London Integrated Urgent Care. There were no particular issues that I would want to draw to the governing body's attention. In terms of cancer services, as Tonya has mentioned, we received the provider annual assessment outcomes for cancer services, which were a very assuring position. We did take a paper with regards to the changes expected around the process for review of child death. And we're working in partnership with the local authority to meet our new publication deadline of the summertime, June this year. And I plan to bring a report back to the committee and then onwards to the governing body to explain how we will manage our relationship with the wider South West London footprint that's required so that we have a significant pool or a sufficient pool of data to be able to draw the best lessons when sadly a child or a young person dies. We did receive the Q3 Safeguarding Adults and Safeguarding Children's report, and we also had the Q3 Serious Incident report. We did talk in detail about continuing healthcare with a particular focus on personal health budgets, and again I'm pleased to say that we're on target to achieve our trajectory for increasing the proportion of patients who are in receipt of and control of their finances through a personal health budget. One area I would just draw to the governing body's attention is the annual report for the Children Looked After team. And we do have a challenge around our initial health assessments carried out within 20 working days. We do have an action plan put together for that, and we have approved the appointment of a named nurse for Children Looked After, which I think will make a significant contribution to that improving over the coming year. But it is an area of concern that we need to make sure that we continue to monitor through the Integrated Quality Governance Committee. I appreciate it's a large report, but I'm very happy to take any questions.
Any questions or comments from the governing body? No? To take us through the South West London performance, is that?
I've covered that just in its, I think it's month 7. I wouldn't go into much detail. The summary of it is on the cover sheet in terms of 5 of the 6 standards were rated as green. And the one area that we're not is in terms of our A&E performance for winter. So overall, I would say it's quite a positive position.
Okay. Thank you very much then.
Thank you.
Thank you, Chair.
Okay. I'll take us to item 2.3, Finance Committee Summary.
Neil.
James. Neil.
Okay, so the Finance Committee met and largely discussed the 2 papers that we have also on the agenda, the month 10 finance report and the financial plan for 1920, which we reviewed, and the committee proposed that we recommended to the governing body that we approved those plans as the budget report. I'll take those as the
Okay.
Okay, so starting with the month 10 summary report, if I ask you to look at slide 5 in the pack, we've summarised the main items for you. So looking down the left-hand column, the CCG is now forecasting a year-end deficit of 3.9 million, as we reported at the last governing body. The risk-adjusted position is a deficit of 4 million. Since the last meeting, we've included the risk of the Chelsea and Westminster Foundation Trust transaction payment of 1.25 million. And we are still negotiating with North West London. We may require mediation to settle that particular point. In terms of QUIP, we're now, or our overall CCG savings programme, we're now projecting a forecast of delivering £12.1 million worth of savings against the target of 16.9 million. That includes the unidentified QUIP programme that we had at the beginning of the year. And the final point in that section, the underlying position is worse than the year-end deficit because we've used some one-off measures to manage our position. However, we're now showing an underlying position of 5 million, which has improved from our last month's report. On the right-hand side, I've just a couple of points on the sort of in-month movements. We've now agreed with Kingston Hospital an overall position of 50.6 million. Which is a small improvement on the last month. And also the position with Chelsea and Westminster has improved. We're now forecasting an adverse variance with them of just over 795,000, which is an improvement on the £1 million we were assuming last month. We've also agreed that because of the Cerner implementation, all of our outpatient transactions will be just treated at plan for the remainder of the year. The adult continuing healthcare forecast has also improved. We're now showing a favourable variance of just over £1 million, which is an improvement from the last report. We've had, obviously, still a number of additional fast-track patients that have come in this month, but we're still able to forecast that position. We continue to have an adverse position on the mental health adult placements, and that has increased our forecast in this month. We're now forecasting an adverse variance of 945,000 for the year end. We've had an additional 27 packages of care agreed in this last period. And the final point I just wanted to highlight was we're now forecasting for prescribing a forecast of underspend of 1.4 million. We've incorporated the pressure of the non-stock availability of, and we've offset that with the Category M changes. Those are the main bits I wanted to just highlight. Happy to take any questions.
Questions or comments for Neil? The 12.1 million quip, that's a significant percentage, is it not?
It is. I mean, we did flag that we hadn't identified schemes of about 6.9 million. However, we have been able to find, as we've said before, some non-recurrent areas to help bridge some of that gap. So yes, it is a significant.
Still been a significant achievement from
yes,
the colleagues who've actually enabled the figure that we've got.
Yes, and I would stress in particular the savings in continuing care are very significant.
I think, well, my thanks to colleagues on the ground who've actually worked tirelessly to achieve these figures, even though we haven't quite got where we would ideally like to be. I think we should still celebrate their achievement. Shall we move on then?
Okay, so this next paper is a sort of highlight for our planning information. Plus, we have, because our next meeting isn't until May, we do need to agree a set of initial budgets so that the CCG can operate as an organisation from the beginning of April. So I'll just take you through the main points. Section 1 talks about the NHS allocations. We've now been set allocations for the next 5 years, and part of the plan is to move all NHS organisations to a sustainable position by the end of the 5 years. There has been a move to move more of the sustainable funds that have been managed by NHS Improvement into the tariff. So the provider sustainability fund has been moved into the payment by results arrangements, and there is a smaller financial recovery fund available for providers. There's an expectation that we will invest above our growth level for mental health, and the mental health investment standard has been set at 0.7% higher than our growth area. There has also been quite a fundamental rearrangement of what's called the market forces factor, and it has been agreed that those changes that have now been modelled will be brought in over a 5-year transition period. It has a significant impact on the London CCGs and providers, and we're modelling that through as we agree contracts. The other main change is that our running cost allowance will be reduced in 2021. So there is something around making sure that we build in sufficient headroom to cope with those restructuring costs potentially. Overall, because of the allocations that we've been given, across South West London, the capitation target moves from 2.6% to being now above target by 4%. There is significant pressure when individual CCGs go above 5%, but thankfully that's not a position for Richmond at the moment. In terms of system working, we've just headlined on the following slide that the headline growth that we've got for South West London is an overall growth of 5.6. About 3.9% is passed directly to trusts through the tariff. So in theory, that leaves us with about 1.8% left for any transformation or any other things that we have to manage in terms of growth, etc. On slide or section 3, the planning assumptions, these are just the details of the top-down assumptions we're making in our planning models. As you can see from Richmond, on the first column on the left-hand side, our overall allocation grew by 5.76%, and you can see the tariff and inflation assumptions we're making for Richmond, and just for comparison you can see the Kingston ones as well. The next slide, section 4, shows how we've developed the financial plan so far. I recognise not everyone likes looking at tiny figures, but we will come back to this in just a moment. The following slide just gives you a graphic of how we've managed the plan. If I just take you through the graphic, as I've said in the previous discussion, we are now showing a forecast deficit of 3.9 million, which is the first block, blue block on the left-hand side. Having taken out all the non-recurrent items, we're left with an underlying deficit of 6.7 million. We do believe there's a full year effect for QUIP, particularly for continuing care, of about £1 million. And therefore we have modelled the plan based on an underlying deficit of 5.7 million. That means that as an organisation, the spend that we have is £5.7 million higher than the amount we're allocated for the NHS. Then you can see the red column shows the cost of the tariff and the growth, so that combines to £18.5 million. We then have the growth allocation, which gives us 15.8 million. There are other cost pressures and reserves that we have to set aside, which gives us a further cost of 5.7 million. And that means that we start before QUIP with an overall deficit of £14 million. Therefore, we have to plan to deliver a overall QUIP savings programme of £14 million to get us back to the deficit position. So if I just take you back to the previous slide, we've been working through this model in the Finance Committee, starting on the left-hand side with the budgets and the forecast outturn that we're assuming. The middle column shows the sort of opening baseline budget that we've modelled through, and we've then from there on in applied the various top-down percentages to come up with a position in the third column from the right-hand side of our budgets prior to any QUIP. We're then proposing to deduct the 14.2 million, and therefore the final column on the right-hand side is the summarised budgets we've proposed that the CCG adopts for the coming financial year. We're clearly still going through a round of contractual discussions with our providers, so we will bring an updated set of budgets once those discussions have been concluded in May. But for the initial period, we're asking that the CCG agrees this is our initial budget. And just to flag, on that right-hand column, the red 6.2 million or 6.3 million shows that we still haven't got a balanced budget because we still have a residual amount of quip that we have yet to identify. And then the final points I just wanted to pick up were just we're still going through our contractual discussions with the providers. They will still carry on. We don't have to agree contracts until the 21st of March. And we've included in the rest of the document the next steps and timetable. I'm going to take any questions on the paper.
Thank you for a very clear presentation. Any questions or queries? So I think we're being asked to adopt this.
Can you just add a couple of points from a sort of context point of view, just to update people on the overall sort of process? So it talks in there about system working and having to work differently. And the 10-year plan also outlines how systems have to take responsibility not just for their own position but the system position as well. And I think it's fair to say we've already seen a bit of a sea change in the way the regulators are working. So we are now as a system being asked to present the system-wide position, so we don't have individual contractual meetings on CCGs or trusts. So it's a very different, it's starting to feel very different in terms of the world that we're working to. Where we're at, if you look at South West London, we had a meeting with regulators on Monday. We've still got, you know, a sizable gap across South West London that we're trying to work through. We'll need to bring that back to a future governing body for what the implications are for both for South West London and what that means locally for the Richmond system and Kingston system, and clearly how that will work through. The money that we've got is the money that we've got. So from South West London point of view, they're saying there's no more money. So when you look at how we manage that across South West London, we're going to have to approach that in a new way, and we'll have to solve that. And part of that will obviously be how we resolve our underlying unidentified quip gap. So I think we'll take that through. We've got the joint, sorry, get the words right. We've got the committee in common for the finance committee that's on top of this, and we'll bring this back to the local finance committee as well, so they can get their view on it. And obviously we'll feed that into future governing bodies. But as we were talking about earlier, you can start to see the sea change in how we're expected to work and the level of responsibility that we need to have and other organisations need to have within the system. So that those debates will evolve.
Okay. Any questions for James on that? Okay.
Sorry, just about the ask about the primary care spend. There is out of our service 1.3 million. Does it include NHS 111?
Yes. Yeah.
Thank you.
Any other questions? So we're being asked to approve this as an initial budget. Are we happy to do so? Yes. Yep.
Yeah.
He's nodding in agreement. Marvellous. So I'm going to move us forward then to item 2.6 and welcome Anna Brighton. So I should maybe have done that at the beginning as our public health representative.
Thanks.
So do you want to take us through the sexual health strategy?
So hopefully you've had a chance to read some of the strategy. We've had, this is really, we're doing this because it's a refresh, so we had one that's just run out. We're now in quite a different context to the last one. So the last one was really focusing quite heavily on our contraceptive and sexual health services and the specialist services, which were recommissioned as part of the previous strategy. So this one's focusing much more on prevention and awareness raising. So you'll see in the action plan there's quite a lot of actions that are related to both young people and adults in terms of prevention, so the role of schools especially, but also primary care and other community settings are in there. Also importance of inequalities. So for example, one thing that came very clearly out of the young people's engagement was about LGBT and how awareness was raised at school, where young people could find out information. And that also came up in a piece of work we did last year looking at risky behaviour services across the council, across the council area. And then the last one is primary care commissioning, which we discussed at the clinical executive team. We did quite a lot of engagement with this strategy, so it's going back a while now, but in summer last year we had a big workshop with quite a range of stakeholders, which was really, really good attendance and really positive, constructive discussions there, and really helped to inform the action plan, so that very much came out of that. Just to try and capture a few more frontline professionals, we also did surveys out to school nurses, GPs and pharmacists, so we got a few more pieces of input from there. And like I said, we also did some engagement with the Children Care Council and the Youth Council. So you will see the action plan in there. That's going to start from April. And so if this is approved here, and it's already been approved from Cabinet a couple of weeks ago, that's the piece of work we'll be getting on with. And that's really us in public health leading that on behalf of local partners. It's not us doing this kind of behind closed doors on our own. You'll see we've put some timings into the action plan. The first year or so is really focusing on looking, especially young people's engagement, looking at how people like to find out information, and also linking into the important work that we're doing around the mandatory relationships and sex education that's coming in nationally in 2020. So that's a big focus for the first year, but you'll see it's a 5-year plan, so there's some longer term actions in there. So it's really just to see if there's any questions.
Thank you, Anna. Does anybody have any questions for Anna on this refreshed strategy?
Just one more to say thank you. It's a really, really comprehensive piece of work. I was just wondering, we talked a lot also about the importance of mental health and young people's mental health, the quite high levels of self-harming and all in the borough. And I wondered how this can link, in terms of linking across health and public health.
Yeah.
The strategy can link in with mental health work as well.
No, it's a really important link, and I think one thing that comes out, not just from sexual health strategy, but other pieces of work we do, is looking at people as a whole, and especially young people. At the same time, probably in spring, summer, we'll also be bringing a substance misuse strategy. So that's a piece of work we're doing. Last year, we were also doing a review with partners around risky behaviour services for adolescents. And there's a lot of work that we're leading at the moment as part of the CAMS transformation plan around preventing mental ill health, and especially the role of schools in there. So it all links together, and by chance all those topics sit in my team. So we are trying to make all these different pieces of work talk to each other.
Excellent. Thank you. It's good to know. Thank you.
Any other questions or queries from Anna on this strategy? Okay, so you brought it here for discussion. There was some discussion and approval. So are we happy as a governing body to approve this as a sexual health strategy?
Yes.
Yep, everybody's fine. Okay, thank you very much, Anna. Which brings us to 3.1 and the NHS long-term plan. Tanya.
Thank you, Chair. I thought it would be useful to bring just some high-level messages to the governing body around the long-term plan. Members will recall that actually the long-term plan was published, I think, the day before our last governing body, so we didn't really have an opportunity to discuss it then. And I think it's just important to just give you some headlines around. I'm sure you've all read it now anyway, so it's all probably old news, but I thought it was useful just to have some headlines. It is a 10-year plan. I quite like, because we're keen in the NHS and with partners to transform services. It is a 10-year plan, and we are expected to, and so the next steps, we're expected to respond as a South West London community to how we're going to deliver the first 5 years in the autumn. So I think it is it's a long-term plan over 10 years. So whilst there's some really good direction of travel in there, some of the detail hasn't yet been published, and we need some more debate and thought about how we're going to deliver the ambitions within the plan. But I won't take you through the pack in its entirety. I just thought I'd give you some highlights. So if we start with the high-level messages, I really welcome the long-term plan because I think it's a real emphasis away from the traditional hospital care to one around prevention, early intervention and reducing health inequalities. So there's a real focus on prevention and early intervention and the health inequalities piece. There will be new clinical standards to be set, built on the success of stroke. So we've had a really good experience from reducing the mortality around stroke and also cardiac, where we have a cardiac network as well. So will there be new clinical standards on for some areas? There's going to be reforms to hospital emergency care. So every hospital with a type 1 A&E department will move to same-day emergency care model, and hospitals will establish acute frailty services. We will roll out NHS personalised care model across the country, and we will boost out-hospital care. And we've started to see that with the recent publication of the guidance around the new primary care networks that came out about a month ago. So we'll start to see how that will look like. Moving on, there's a renewed commitment that mental health services funding in mental health services will grow faster than the overall NHS budget, and Neil has explained how we are meeting that in Richmond. And we are going to also guarantee NHS support to people living in care homes. There's greater recognition and support for carers, and probably the priority that is interesting and having lots of debate at the moment is around about integrated care systems. So integrated care systems will be rolled out across the country by April 2021. So you've got quite a lot of detail in your pack. I wasn't going to go through all of it, as I said. I thought I just would touch on the integrated care system slide. That's a couple of slides in, sorry, they're not numbered. So the long-term plan sets out the ambition that we will move to create ICSs everywhere by April 2021. And there typically will be a single CCG for each ICS. And I think I talked about in my managed address report a piece around the moving forward together. So that's what that long-term plan does say. And the purpose and the ambition and the vision for integrated care systems is a practical way to deliver what they call triple integration. So integration between primary specialist care, integration between physical and mental health services, and integration with health and social care. So a real positive ambition around how we bring services together. As how our populations have been saying for a long time, that's how they would like to see services delivered. There's a key role in working with local authorities at a place level, a place being a borough, and I'm very pleased to say that we already have established really good working relationships with our local authority. So that's really a good endorsement that we carry on that work. And I think probably the fundamental change for a lot of us culturally is neither trust nor CGs will pursue actions which, whilst potentially improving their institutional financial position, will result in a worse position for the system overall. There's a new duty to collaborate for providers and CCGs. So we're starting to see the dismantling of what has been traditionally called the commission and provider split, which again, I think anyone around this table would welcome, as actually this has historically had some benefits, but also some challenges as when we want to transform care. So I wasn't going to go through all of it, and you can read it at your leisure if you haven't read it before. I think the next thing I wanted to say now was about the next steps in implementing the plan. And some of those next steps we've started to emerge already. So one of the first things was the NHS Assembly to be established by early 2019, and I believe they've appointed in London the leads for that assembly. I think that is, I believe they have, if it hasn't been made public knowledge yet. I think it was announced though. And we have the National Implementation Framework published in spring 2019. The Clinical Standards Review will be published in spring 2019 as well. There will be a new National Implementation Programme by autumn, and we will see the need to develop the ICS programme across that time period. And as I say, as I said at the beginning of the presentation, we will have to develop and implement our own 5-year strategies to set out how the ambitions in the plan will be taken forward, and these will be published in the autumn. And of course, locally, we are developing our plans very much bottom up, and our local health and care plan will be the local response to the long-term plan. So all those people who have been involved in the development of the local health and care plan today can see that that fits in as a local response to the long-term plan. Workforce implementation plan will be published later in 2019. As I say, we're moving to create ICSs or integrated care systems everywhere by April 2021. And we will look, we are looking locally on how we need to ensure that our transformation programs that are in train actually map against those long-term plans. But I'm pleased to say that in Richmond, all the plans that we have in place have been taken forward. They do map to the ambition in the long-term plan. So that was all I was going to say about the long-term plan, but I'm happy to take any questions, queries, comments, reflections.
So, any thoughts from the rest of the governing body on what is probably one of the biggest changes to NHS planning in the last decade at least?
It's a bit old news now, isn't it? It's all old news. It's all old news.
Read it cover to cover, obviously, and that's still assimilating.
Yes.
Okay. Thank you for your report, Antonia.
Thank you.
I'm going to move us on then to item 3.2, which is the board assurance framework, which we discuss at every governing body meeting and most meetings within the governing body. Vicky.
Thank you, Chair. So in the paper you have a summary of all our organisational risks, and then you have the detailed board assurance framework, which details all our risks and controls for those risks that have an inherent score of 9 or above. We actually had a risk management audit undertaken at the end of last year across all the CCGs in South West London, that found that all the other CCGs only pull through to their BAFs those that have inherent risks of 15 and above, and so they recommend that we do the same. Okay. So one of the decisions for today is to approve that approach. But the audit gave us a rating of reasonable assurance for our risk management processes. So in the pack, you have the detail of the risks, as I said. There are 3 very high risks for Richmond CCG, and they are all around the finances, as you'd reasonably expect. I think that's all I want to say as a general overview. If anyone's got any questions, particularly around the detail of the BAF, we can take those.
Thank you, Vicky. Any thoughts or comments from the floor? So we're being asked 2 questions then. We're asked to note the content of the board assurance framework, which a lot of us will have seen frequently, so I presume we're all happy to note that. Yeah. Then we're also asked to approve the internal auditor's recommendation to align with the rest of South West London. I suppose my only question is, I assume we're all scoring in the same way?
Yes, we all use the same matrix, and all it means is that those risks of the score under 15 are just routinely monitored through our subcommittee process rather than putting them through to the governing body.
Okay. Does anybody else have any questions to Vicky on that? Otherwise, are we happy to approve that internal auditor's recommendation?
Yes.
Yep. Thank you very much. Right, we've got a number of minutes from various committees which are here for information. Does anybody have any queries or concerns over those? Okay, if not, then I'm going to remind everybody that the date of the next meeting is the 7th of May, and that's back in your case, which is where I drove on autopilot this morning. Realised it was somewhere else. So hopefully everybody else will look at their calendar in a timely fashion. Is there any other business?
Can I just mention, Chair, our Director of Public Health, Huda El Sharif, is retiring at the end of March.
Yes.
We will be sending out some external comms in the next few days to everybody, just in terms of going forward, and who will be the representative on the governing body.
Thank you. I have worked with Huda since various other three-letter acronyms, PCTs, Gs, CCGs, and can I take the opportunity to thank her for all her work that she has done with the NHS over the years and making public health prominent in the way that it perhaps was not before I'd met her. So if I can take my personal thanks, and I think the thanks of this committee.
Oh, absolutely.
For all the,
Yeah.
all the work
Yeah.
that she's done. So I think with that, if there's no other business, we're going to move on to public question time. So members of the public present are invited to ask questions of the CCG governing body relating to the business being conducted. Priority will be given to written questions that have been received in advance of the meeting. We have received none, but I can see we have members of the public here. Does anybody have a question for us? Wendy. I'm sure we have a governance structure
We can share our
that
governance
we
structure.
could share with you. Yes.
Might not be an easy read.
Well, have a look at it, and if you have any questions to come back at us with, that would be helpful. Any other questions? Well, I wish everybody a safe journey home before it starts to rain this afternoon.